Howdy y'all, I'm Dr. Jeff Jarvis. Welcome back to another video on performance measures. We're going to pick up where we left off. I'm joined by Kirby again. Kirby, thank you so much. Let's talk some measures, shall we?
Yeah, let's do it.
Next up, pre-arrival notifications. This is, again, the denominator, primary or secondary impression of STEMI, or a STEMI alert. And in this one, we need to notify the hospital of an incoming STEMI within 10 minutes of the first positive ECG. I want to be clear, that is not the first ECG.
No.
Now, in most cases, it probably will be, but the way we measure this is we go in for each 12 lead and determine whether that was interpreted as a STEMI or not. And how you document that turns out to be important.
Yeah. So talking about the documentation portions of this, Dr. Jarvis mentions that we do use the primary impression section a lot. So when you have a STEMI patient, or you suspect that your patient is experiencing a STEMI, we do actually look for that. We go off of the primary impression as well as the secondary impression. As long as STEMI is in either one of those fields, you'll be able to be included into this measure. We also want to make sure that we are documenting our 12 leads, which will come over from the monitor for us most of the time, which is great, and that it is marked as a STEMI or suspected STEMI, along with a notification activation for a STEMI alert. Now that is in your transport and destination information section. It's very important that you put that activation there. And don't forget that there is a situation tool that you can use when you have a STEMI patient. Over on the right-hand panel, you can click that. It says STEMI. Click on that and you will have everything that you need to document according to the right times in your chart, so that it makes it easier for you to complete later on after you do your patient care and run the call.
Perfect. So when you do that, we're able to determine, let's say your first ECG was not a STEMI, but you had the heebie-jeebies about the patient and the 12 leads, so you did the appropriate thing. You got another 12 lead. That one was a STEMI. When you document it the way Kirby just told you to, we'll be able to set that pre-alert notification 10 minutes from the first time you knew it was a STEMI, which is only fair. You're not supposed to notify if the damn thing's not a STEMI.
Right.
Makes sense.
It's recognition, right?
Recognition.
And that's what we go off of.
Let's talk stroke.
Strokes.
We know that a big stroke mimic is hypoglycemia. So for our patients who we say our primary impression is stroke, or we call a stroke alert on, we need to obtain and document a blood glucose. We're doing pretty well on this, and we consistently have. Definitely doing better than the benchmark. Strong work. Stroke screens, we know we need to do the stroke screens and we need to document them. For this measure, it's looking only at Cincinnati. It's not looking at the LVO screens.
Right.
We need to make sure that we're documenting it and documenting it appropriately. We're doing so in February. 86% of the time. You can see our running average is about 89%, exceeding benchmarks, but I still think we can push that up even more. So I think the key thing here is make sure you're doing it and make sure that we're documenting it appropriately.
Right, and remember, in the appropriate place in the documentation has actually changed over the past year. We did relocate where that is at, and again, we do go off of the primary impressions. It's kind of a trend here. We look at that a lot. So it is going to be in its own panel now in your patient care section. It is in the stroke assessment panel, and you will be able to see that you can document a Cincinnati or a Lamb's scale, and that Cincinnati one is what we're looking for, along with those timestamps, and of course, the last known well, but I'm jumping ahead of myself a little bit here. You're going to talk about that next.
Talk about last known well.
So the last known well is incredibly important because we do definitely need to know how long have these symptoms been persisting, right? So the hospitals want to know this information. We want to know this information. This is a regular part of running this type of call. We already get this information.
Right.
The thing is, we definitely need you to put that in your chart, right? So that is going to be in the same section, in your stroke assessment section. It is the first option that you have to document that last known well.
Perfect. Well, how are we doing on pre-notifications? Well, pretty well. 90% in February. Our 1 year rolling average is 86%. Goal is above 75. We're doing well on that. I think we should be above 90%. We're there in February. Let's keep getting there. So good work. You mentioned last known well time. In February, 79%, rolling average is 82. Not bad. We're beating the benchmark, but I think we can do better.
Yeah.
Make sure this is one that really matters for patients.
And we do get it, right? I can't imagine too many times where you don't try to get a last known well time. So
Yeah,
if
just
you're
make
getting
sure
it,
we're documenting
yeah.
it and getting credit for the work that we're doing.
Exactly.
I think that's reasonable. Asthma 01 is you had a patient with an impression of asthma or bronchospasm. Did you give them a beta agonist? Nationally, we suck at this. Here in the Fort Worth area, we rock at that. Definitely not a good time to use the term smoking.
No, not.
So 97% in February, we've been averaging 89. We ought to keep it above 90, but overall, I think we're doing good work here.
Yeah.
Now, one thing I do want to point out is we're hitting impression over and over and over again.
Yeah.
As I go around the country talking about these measures, I find a lot of people that medics who are documenting an impression, they're not clear on what that is. I think we're pretty clear on it here, but I just want to reiterate, that is not the chief complaint. It's not the call nature. It's not what came from dispatch.
Right.
It's not what the patient complains of. It is your diagnosis. It's what you think is wrong with the patient.
And to bounce off that a little bit, where that translates to in your image trend chart is going to be the provider's primary impression. It is a drop-down list. There are pre-selected items that we have activated in those fields for you to be able to use. We're not talking about that working diagnosis, which is the free text space. Unfortunately, we can't use those for these types of things,
Yeah.
even though we do look at them and definitely pay close attention to them. But that primary impression, you'll notice that we did narrow them down a little bit ago, I think maybe 8 months or so ago when we kind of revamped the entire
was
system.
prunage.
Yeah, we kind of pruned some things out. So hopefully it's a little bit easier for you to search through. Those are what we're talking about when we keep mentioning or referencing the primary impression, along with the secondary too.
From a NMSIS standpoint, what NMSIS will allow in that field is any ICD-10 code.
Yes.
There are, approximately speaking, and this is a scientific term, a crap ton of ICD-10 codes.
really
you
are.
do not want to have all of those to select from. So we have to do some prunage,
Right.
and that's what we've done. So let's talk hypoglycemia.
Yeah.
Kirby, there you were in the field. You have a patient with a blood glucose of 59.
Oh boy.
Let's say I have a blood glucose of 59. Are you going to start an IV on me and give me dextrose? Probably
Do I
not,
wanna treat that?
if you walk near me and try to stick me in the finger, I'm probably going to have a problem with that. So when you look at hypoglycemia treatment, I think it's important to understand the entry criteria, the denominator. So these are patients with a blood glucose less than 60 and altered mental status.
Yes.
So it's not just the hypoglycemia, it's that they're altered and hypoglycemic.
Yes.
I don't think anybody would argue we should treat those people.
Correct.
Now, there are different ways of treating it. For example, if my altered mental status is that I'm being a really nice guy and normally I'm kind of a jerk, and I'm hangry, or vice versa.
Get you a Snickers.
You can get me a Snickers, right? And that counts.
Yeah.
So we made some tweaks to Image Trend. If you go under procedure, you can now document provision of food under procedure. So if you give them a Snickers bar, if you give them a peanut butter and jelly sandwich to get their glucose up, let's get credit for it. This is how you document it. So overall performance, 69%. We're clearly beating the benchmark, but we can do better.
Yeah.
Let's talk the breathing things, and definitely don't need to say smoking these measures, but we're doing really, really well. Respiratory assessment, the denominator is any type of respiratory complaint. The numerator is those patients with a respiratory complaint that we did a respiratory assessment on. All we're doing is documenting at least one pulse ox and respiratory.
Yeah.
That's not too much to ask, is it?
No, that's pretty
Good.
standard too.
And it turns out we're doing really well on this.
Yeah.
Don't want to say smoking, but we're doing well on it.
We might be smoking though.
We might. How do we do on those patients who are hypoxic. Do we have a treatment for hypoxia? Do we have something we can
I
give?
believe we do.
Oxygen, maybe.
Yeah.
Yeah. So of patients with an SpO2 less than 90, what proportion did we give oxygen to? In this case, 59. Now, that's better than the national benchmark, but I think we can do better. Now, I will tell you that we are working on this I'm going to put my NEMSQA hat on. We're working on this at a NEMSQA level. We have a problem with bad pulse ox data. So let's just say you have a 18-year-old perfectly healthy woman who sprained her ankle or did something not involving lungs. Put the pulse ox on, she's at 100%. 100% except for that time that you hit a bump, the pulse ox probe came off, and now we record the pulse ox of the stretcher, not the patient, and that gets imported in.
At perfect timing, right when it captures a vital sign.
Exactly. So if you're looking only at imported data, you had to have a pulse ox of 20 and you didn't give oxygen.
Right.
Well, you didn't give oxygen because you know that the stretcher is not going to benefit from the oxygen.
Right.
And the patient has a SAT of 100. You confirm this by putting it back on, and sure enough, it's 100.
Right.
The thing that we can do about this is when you import your data, remember, you can review it. Just take a quick glance and go, do these vital signs make sense? And if they don't, either delete them or fix them.
Right. I think a good example of that would be if when you import your data, and we can kind of look through this here together, that you're checking your vital sign entry and you're scrolling through that section to see, was this a hypoxic patient? Was this SpO2 recorded correctly? And if they were hypoxic, the next thing we want to make sure we do, as long as we're treating that hypoxia, is we document the administration of oxygen. We do need those administrations of oxygen to be documented. It is a medication we give, right?
Sure.
Yeah.
Yep. Hey, status seizures,
Yeah.
epilepticus, probably ought to treat that. We know the treatment of choice is benzos. We carry a benzo by some coincidence.
We do.
So we need to measure. We know this is a life-threatening event. We can have huge impacts on our patients if we treat them. So the primary, or the denominator here, is primary or secondary impression, not of seizures. You can document a seizure.
Right.
That won't get in here because, as we all know, if you've run more than a few of these, most people who have seizures stop on their own, don't need us, and certainly don't need a benzo.
Right.
This is status epilepticus. Status epilepticus bad. They need benzos. Except the definition of status epilepticus is a prolonged seizure, not stopping. No doubt those people need benzos. You walk up, they're still squeezing, we know we're going to treat those.
Right.
No doubt. But you can also appropriately diagnose a patient with status epilepticus is if they have had 2 seizures, that they seize, stop, seize again, and they never return to baseline. That's status epilepticus, regardless of whether they're seizing in front of you. If they're not seizing in front of you, then they don't need benzos. So how do we get around this? The key way is that not indicated button. So you go into medication. So anytime you put status epilepticus in the impression but don't treat, please go in, document the medication of midazolam, and then click on that little round negative button and say not applicable. Get credit for it. It's easy. You're not falsifying records. You're being really honest.
Yeah.
That's just what that thing is put there for. Those are called pertinent negatives in NMSIS speak, and that's why they're there. So that's how we can improve this measure. I really don't think that 61% of the time, 41% of the
There you
time,
go.
we're not treating actively seizing patients. At least I hope that's not right. But I think we can improve on the measure.
Sure.
In one of our last episodes, we talked about syncope patients and why they need a 12 lead. So first off, I think our performance on this, not so bueno, 74%. This should be well above 95%. Basically, if you have a syncope patient, I don't care how young, how old they are, get a 12 lead ECG. We're doing it, our rolling average, 70% of the time. Again, should be better. But I think 2 things are important here. Number 1 is, what is a syncope? What is the definition of syncope? Because I think we call some things syncope that clearly are not.
Right.
And then number two is, why am I asking you to get a 12 lead? So let's deal with the definition first. A syncopal episode is a transient loss of consciousness that is postural. So that rapidly resolves.
Right.
So I am sitting here and I slump down and then I wake up. I fall to the ground and I wake up. That's a syncopal episode. Let's think about this. I know hypoglycemia can cause altered mental status. Can hypoglycemia cause syncope? No, it cannot, because if you're altered because you're hypoglycemic, you're going to stay altered as long as you're hypoglycemic. Nothing about going to ground, unless you impale yourself on a glucagon syringe, is going to improve your hypoglycemia. Yet you're no longer unconscious. So hypoglycemia cannot cause syncope.
Right.
So what are the causes that we're looking for? Well, we're looking really, there's basically two things. We are looking for outflow obstructions. So aortic stenosis is a big one. It's like the one heart sound I know and care about. But the main thing we're looking for is arrhythmias. So patients have syncope when they don't get adequate blood flow. One main reason that we can do something about is if they go into an arrhythmia. VTAC, for example, VFib. So yeah, we're looking for a STEMI, but we're also looking for Brugada, we're looking for WPW, we're looking for prolonged QT, we're looking for HOCM, all things that, you know, now that I think about it, we should probably do another video on. But that's why we're doing a 12 lead. So the key to getting this measure up is, number one, realizing you got to do a 12 lead on syncope. And number two, if it's hypoglycemia, they probably don't need a 12 lead, but it's also hypoglycemia. It's not a syncopal episode.
Right.
And I think we probably fall out of this because we overdiagnose syncope. Rather than, that's what I'm going to like to think.
I would agree with that too, and I think that a lot of it does have to do with reported syncope to us, and you know, different versions and various ways of describing syncope,
Right.
which may not actually be syncope. The diabetic patient is a very good example of that. However, the syncopal episode or syncope actually does end up getting put in the chart,
Right.
which is of course natural and what we
Yeah.
would look for. So
Just not what that means.
right, it's not what that means. So pay attention to where you're putting it in the chart, right? And then of course just getting the 12 lead, which I don't think we have any issues with.
Yeah.
I'm sure we take plenty of 12 leads every day.
So I will tell you, I do, if a 3-year-old comes into my ER with a syncopal episode, even though I'm going to be kind of skeptical about whether syncope was actually involved or not, I'm getting a 12 lead.
Sure.
They're cheap, they're easy, they're
Why not?
crowd pleasers,
Yeah.
and I might pick up something.
Right.
Probably not in a 3-year-old. In a 13-year-old, yes.
You never know.
There's a reason you have to have a 12 lead before you play athletics now.
Yeah.
They're looking for HOCM.
Yeah.
So, hey, let's talk TBI. There was a study that was called EPIC, and EPIC looked at what are the things we can do to improve outcome of patients with traumatic brain injury. And it turns out hypoxia, hypotension, and hyperventilation, those are collectively called the H-bombs, kill patients with TBI. Kill them, dead, bad.
Yeah.
We don't like that. We need to avoid hypoxia, avoid hypotension, avoid hyperventilation. Wouldn't it be great if we could measure those three things?
Would be.
Oh, we can.
Yes, we can.
We can measure SpO2, we can measure end-tidal CO2, and we can measure systolic blood pressure. For patients with a TBI, and that is defined as one of a variety of primary impressions. It's basically trauma,
Head
and
injury.
something to the head,
Yeah.
and GCS less than 15.
Yep.
You need to document SpO2, systolic blood pressure, and end-tidal CO2.
And the good thing is, those are pretty standard for us to document.
Apparently not. So,
Well-
if we look at this, national performance is 16%. Holy crap. 16%, really?
Yeah.
16%. And we're not much better at 37.
Yeah.
Honestly, no clue why. We're looking into it. Hopefully we'll find easy things that will help us improve this. I'm not sure why. I have a really hard time believing we're not doing that. So more to come. We're going to look into the measure.
Yeah, I think I have some ideas. I think that when it comes to a measure like this, there are various different ways you can look for this within documentation, right? And back to our primary impression discussion, that's where you really want to be specific. So if you're trying to communicate, this is what I think is really going on with the patient, that's where you're going to put these specific types of things: head injuries, loss of consciousness, pain due to trauma. Indications like that need to be really, really solidified in your primary and secondary impressions, as well as in your assessments, right? So if we can nail those types of things down and really make sure that if we have a ground level fall, but we suspect that the patient has a head injury as a result of that ground level fall, I think my primary impression is going to be a head injury, not ground level fall. And that's just an
Maybe.
example, right? So
If you
kind
gotta-
of looking at it that way can help.
I think the way to think about this is just get a full set of vital signs on every patient.
Absolutely.
And then we'll nail this.
Yeah,
So regardless of the primary impression, we ain't getting a full set of vital signs
it
on
appears
these
so.
patients. So we need to just, we're going to continue looking into this, but just try to help us out and get full sets of vital signs.
Always room to improve.
Always. Speaking of vital signs, pain assessments in trauma patients. So we have a field for injury
Yes.
or not injury. If it's an injury, that's trauma. We need at least one pain score. 91% of the time, we're getting there, and you can tell there was a sharp uptick in this. We made a validation rule.
Yeah, pretty
Do
simple.
this. Yeah, so it works. I think this is going to continue to get better and better. Now, interestingly, if we're requiring you to get 2 sets of vital signs and you do it more often, that increases the number of trauma O3 in the denominator. So now we have more patients with multiple vital signs. Trauma O3 says of those trauma patients with at least 2 sets of vital signs, was the last pain score lower than the first? So this is what is the effectiveness of managing our patient's pain.
Right.
And it's not asking what you did. It's not even asking if you did anything.
Right.
It's just saying, did the patient's pain get better? So what I would ask is that you recognize that pain is one of the number one reasons people call us. It's also one of the number one things we can do to make patients feel better. We don't have to give everybody fentanyl. Please don't give everybody fentanyl. But you can splint, you can give cryotherapy, you can give oral medications, you can give ketorolac, all of those count, and they help improve the pain.
Right.
The other thing we can do is actually pay attention to the pain score, and if your patient is alert and awake, ask them.
Yeah.
And then don't just assume and put the same number down twice.
Yeah.
If you put the same number down twice, and that's not what the patient was telling you, you're going to blow this measure, and wow, we're not doing well. Even though it's better than national, still not doing well. So those are some thoughts about why. Trauma 08 is you have any injured patient. Did you get a full set of vital signs? We're nailing it. We're doing really well on this, which is the reason I go back to the TBI one. And I'm like,
weird to
there's
see the
something
difference.
in that.
Yeah.
We
have to
gotta
dig into
nail
that a
that
little bit
down. And that's
deeper.
the reason I'm not willing to say we're not doing. I
Yeah.
think we are.
Yeah.
We just we gotta work through it. TTR, I always, even though I'm responsible in part for this measure, I can't remember what the hell it stands for. It's treat and something, basically this is a refusal.
AMAs, yeah.
So if you have a patient from a 911 call that does not result in a transport, did you get a set of vital signs? Historically, we do pretty well, much better than most people. We can still do better.
Yeah.
Just make sure you're getting a set of vital signs. I'll tell you that if you look at most other departments, just looking at their rate of refusals, for some weird reason, in the middle of the night, the rate of refusals goes up.
Strange.
When you get toward the end of a shift, the rate of refusals goes up. The documentation gets worse. That doesn't happen here.
No.
The rate is the same all the way across the board.
Very consistent.
I think that is a testament to y'all doing the right thing for the patients. So,
Yeah.
strong work. And guys, that's what we have for you right now. Perfect. If you ever have any questions, please reach out, let us know. I wanted to go over, give you an idea of what you're seeing in these measures, and why they're important. We're going to put this up down in the cantina because this is measuring your performance, and I want you to know how you're doing. Now, the other thing that I think is really important for you to understand is how we use these. I will not, this is a big thing for me, generate performance measures for an individual.
No.
These are system issues.
Yes.
And I'm only doing them at a system level. I don't think it is an appropriate utilization of performance measures to measure individual performance. So I don't do that. I don't want you to worry about this. This is all of us improving care for our patients.
Yeah.
So with that, thanks a lot, and y'all have a great day.